Good morning, everyone. It's great to be here in this beautiful space.
Hello.
Nice to see you, Curtis.
Nice to see you.
How are you? You're good?
Yes.
Good. Thanks for having us again this morning. My name is Mark Ishaug. I'm the CEO of Thresholds, and very excited and honored to be with you this morning. Since it's a really small group, I hope we can also go around so we can get a chance to know who we're speaking with for the next 40 or so minutes. And this is my colleague Jill, who will introduce herself.
Yes, hi, good morning. I'm Jill Valbuena, and I'm the program director for the Justice Program at Thresholds. So I'll talk a little bit about that today in relation to the topics you all have been studying in these weekly meetings, which are very impressive, by the way, by the lineup I've seen of the speakers you have, really impressive.
Yeah, and I'm glad I get to practice for 50 minutes with you all today because I'm coming back in February with a whole bunch of folks, including a colleague named Pam Rodriguez from TAS, who I work very closely with. So thank you. So can we go around real quickly? If you could just tell me your name and what connection you have to this program this morning, if any. Or
I'm Dorothy, and when your Thresholds was on the corner of Lakeview and Wrightwood,
Yep.
I lived on Wrightwood just a few steps away from there, and so I used to see that
Got it.
quite often and walk by.
Wonderful.
That's about the only connection. that
Okay,
I have.
great, yeah.
But I saw it and was interested enough to look and find out a little about what you did.
Got it. Okay, yeah, we were there for many, many years, and we
Yes.
sold the building a couple of years ago. Yes, ma'am.
I'm Helen Fisher,
Okay,
and I'm interested.
nice to see you.
I'm Joe, and I'm interested in
Okay.
I'm Curtis. I have known Mark for 6 years.
Very
I've been
good.
in the Thresholds program for over 10 years. When it started back when the oldest center was in Lakeview Club, 20,000 North Lakeview. We're now at 4423. And I hope we can talk more about the changes for the worse that's gone on in Ravenswood.
Okay. This might not be exactly where we take on those challenges, but we can certainly talk about them after the program. Yes, ma'am.
Hi, I'm Elizabeth, and
Yeah.
I'm Dr. Mark out here. My mother's a member of this parish, and I am a nurse who was in the Army, and I've just returned to the United States and to Chicago, and I'm starting my professional career again with an intense interest in working at Thresholds.
Oh,
And learning how to
fantastic.
use. Yes, there we go.
Wonderful.
And my name is Mary. I'm a childhood friend of Elizabeth's, and she invited me along. So,
Great. Welcome, Mary. Yes.
Thank you. I'm Suzanne, and I have two connections to Threshold. One is I had invited your director of research, her name is Chrysostom, to attend a focus group at Loyola University, and that was a couple of years ago. To learn more about your programming. I'm working on aging in place and healthy aging.
Oh, fantastic.
And then my other connection is really brought me here definitely is that my brother-in-law Leo is on the board of directors.
Oh, my God, I love Leo.
Loves you.
He's new. He's newish, and he's wonderful.
Yeah,
Yeah, we're very, very lucky to have him. Well, thanks for telling me. I'm going to see him in a couple days. Thanks for sharing that. I really appreciate that. Yes, ma'am.
I'm another Elizabeth. I'm also a member of this parish. My work is doing communication and consulting with nonprofits on visibility and marketing. And so I thought I might see more about what you're doing and maybe even some help.
Thank you.
My name's Kate Fowler. This is the first of these forums I've been to that I've come to the Bible study with Pastor Smedley. And he was talking about this group. I've been involved with the County Department of Corrections for some time. And for the last 3 years I've been leading worship in the divisions with our team.
Wonderful. Thanks for being here.
My name is Chuck. I don't have any connection with this society.
Thanks for being here. Hi, Mr. Meter.
Thank you, Peter. We've had relatives, including your son, with Thresholds for many years. You do an outstanding job.
Well, thank you.
Very much appreciated.
Yeah, it's people like Jill. I just am the CEO. They do all the work. Yes, ma'am.
I'm Caroline. I'm Elizabeth's mother. I'm a member of the parish, and I come to anything that John Matisse will be.
Yes.
My name is David Duggan. I'm a one-time criminal defense lawyer, member of the board of St. Leonard's House, which was the oldest halfway house in the state of Illinois, founded by a Episcopal clergyman back in the late 40s. I live within 3 or 4 blocks of the Thresholds facility in Clifton, I believe, and I'm a writer on matters pertaining to the faith, the justice system, and the intersection of the two.
Barbara, and I interviewed the other piece for very well done. I practice international immigration law, and in the immigration field, criminal law has taken a whole role, and we call it criminalization. I also have some ADA litigation involving a client who has some conditions that could be reflected in some of the things that you treat and address in your organization. He's got major depression, panic attacks, and anxiety disorder. And the law was not properly applied to him. So I can see where people who have these types of conditions in society, when society has rules that are collared, can end up in some very serious ways. So I see some connections.
Right. Thank you for being here.
My name is Marilyn, and I'm retired, but for many years I had a client who, from time to time, had mental health issues and overcome either thresholds. She also was donor thresholds, so I'm just curious to know more about what thresholds. Thanks so much.
Thank you, everyone.
Great. So thanks so much for being here. It's really an honor to be with you today. So we have I'm going to do a couple of introductory slides, and John has graciously agreed to be our clicker here. So Thresholds is... Stay in front of you. So we've been doing this amazing work for almost 60 years now. We were founded in 1959 to assist and inspire members, the people that we serve, to reclaim their lives by providing them with supports and skills and encouragement and everything that they need for hopeful and successful futures. What I say to a lot of audiences is that we try to prevent the major institutionalization of people with mental illness in Chicagoland. And for me, those institutions are the institution of homelessness, the institution of jail and prison, the institution of emergency room and hospitals. We spend a lot of money in this country, I would say, in warehousing people in nursing homes and other facilities, in hospitals for long time stays, and of course on the streets. And so what we try to do is break that cycle and give people everything that they need, the medical, the psychological, the psychiatric, and the social supports, from case management to supported employment to supported education, so that they can live their fullest lives in the community, hopefully in their own apartment and in their own home, surrounded by family and friends and loved ones. And that we are there to be part of that journey to recovery. We believe that everyone at Thresholds and everyone with serious mental illness can recover. For many people, the recovery term is very associated with alcoholism or drug use, but in the mental health world as well, we talk a lot about recovery, that your diagnosis is not your destiny. And we have people in the room that can obviously talk about that from their own personal experience and from their children's and loved ones' experience. So we're a fairly large organization in metropolitan Chicago. I don't know what the next slide is exactly. I can't remember. It's basically everything that I said. Well, that's good. I was ahead of myself there. But we operate in 9 counties right now, Chicago and the collar counties. We have 1,400 full and part-time staff people doing wonderful work in housing and medical care, in outreach and case management and housing. And we served last year, I think, almost 17,000 people. So while we're really big, and 17,000 sounds like a lot, it's not, given the enormous need that there is in Greater Chicago. But we have about 5,000 or 6,000 members that are in sort of more intensive, continuous care, and we touch the lives of many others through care coordination projects, through our primary care partners at our co-located sites in Chicago and in the suburbs. And we provide housing for a lot of people. We own 600-700 units of housing. We support another 1,000 or so with vouchers and other programs that we help manage. And then we helped, in the last 6 years, move over 1,000 people from nursing homes to the community. And we played an instrumental role in finding housing and supporting people to live in the community. But what we're going to focus on today, we can talk about all of those things as well in the short time that we have, but we're really going to focus on our justice work and what we do and have done at Thresholds for a long, long time to both serve people coming out of correctional settings, including Cook County Jail and the Illinois Department of Corrections to a lesser extent. But really everything that we do, our not so secret sauce in ensuring that people get the support and indeed the love they need to not be incarcerated or re-incarcerated. And so we're really excited to talk to you about our programs and what we do there. And so I think we're going to try to talk at you for a little while, but really use the limited time that we have to talk with you, to hear from you, and to answer any questions that you might have. So more statistics here about all the people, the kinds of people that we serve, our veterans, those that are deaf and hard of hearing, young people, moms. Somebody in the room mentioned they knew that our moms program on Belmont, serving moms with very young kids, very young moms, I should say, with very young kids, and then of course the justice program. So without further ado, I'm going to turn it over to my esteemed colleague here. I'm a newbie at Thresholds. As Curtis said, I've only been at Thresholds for almost 6 years. But like Jill, like so many of my awesome colleagues at Thresholds have been at Thresholds for 20, how long for you?
About 20, yeah.
20 years, yes. Several of the people in my smaller management group, like the average tenure there is about 35 years. So we're very lucky to have so many committed people that have really committed their lives, their professional lives, including Jill, to the good work that we do. So I'm going to move out of the camera and let Jill go.
Thanks, Mark. Would you mind just bring some of the slides?
Next slide, sorry.
Yeah.
Tell me.
Go a couple more, actually. There we go.
That's fine.
That's fine. Yeah, the slide just previous mentioned, I think, actually, can you go back one?
Yeah, it's just a second.
It's NAMI, which is the National Alliance for Mental Illness, indicated that 44% of people with serious mental illness have been arrested over their lifetime. So that's a much significantly higher number than the average population. 29% have been arrested within the past year.
Wow.
So that is an issue that we, in particular, try to address at Thresholds. A lot of the contributing factors to that include homelessness, lack of access to adequate health services, community mental health services in the community. Co-occurring substance use is often common with folks who are self-medicating for untreated mental illness as well. And as I mentioned, homelessness is a really huge contributor to the issue of individuals ending up incarcerated. If someone has a serious mental illness and is on the streets in the city, they're much more likely to come to the attention of law enforcement, even if their issues, typically the folks we serve, I would say, commit what I would call crimes of survival. So people are, criminal trespass or retail theft, things of that nature. And we see that about a little over 50% of the folks entering the jail are entering the jail homeless, and most commonly when they exit, they will be homeless as well, which can also kind of contribute to that cycle of getting back into the system without any other options. I'll do a brief overview of the history. I don't want to go into too much detail, but Threshold started in 1997, our program working directly with folks at the jail. And to this day, we continue to work really closely with them. The jail has, run by Cook County Health and Hospital Systems, is CIRMAC Health Services, which is certain units in the jail that serve exclusively detainees who have either psychiatric or physical health issues that need more medical attention. So we work very closely with the social work staff at the jail, and then also with Cook County Adult Mental Health Probation to intervene at the point when folks are in the jail, but with the purpose of being to help with discharge planning, helping people move back out into the community and stay in the community by engaging in our intensive community supports. We've had a lot of kind of changes over the years. I know initially, I think the title of this was really more related to Department of Corrections. We definitely do less work with Department of Corrections, unfortunately, than the jail, and it's really a lot of funding issues due to Medicaid and Social Security getting cut off. There's so many challenges, but I won't go into too much detail about that. We're hopeful now, and we'll see how things move forward with the Affordable Care Act, but that has helped a lot of folks for whom historically it was hard for them to get any health care at all upon discharge from the jail because they did not have access to medical insurance. So, we are very fortunate currently in that we have a generous grant from the Chicago Department of Public Health that helps support our ongoing works and efforts with folks who are in CIRMAC and exiting the jail. And then we also just recently received a grant, actually it officially started Friday, from the Cook County Justice Advisory Council that is allowing us to expand our work with adults who are on mental health probation. So oftentimes, if an individual with a serious mental illness is released on probation, they will be assigned to mental health probation. Mental health probation typically requires that individual work with a mental health provider. However, we typically don't take mandated clients. We are a voluntary organization, but through our relationship with probation, oftentimes folks are referred to us. As I mentioned, we're a voluntary organization, so if people choose to work with another provider, that's fine. But it's a good partnership in the sense that if someone is out on probation, there are certain things that they need to do in order to make sure that they don't go back, and they oftentimes need a lot of support in order to make that happen. Because as I said, we're working with a lot of folks who are entering and exiting the jail with homelessness and untreated mental illness, which is a significant barrier to successfully completing probation. Over 50% of individuals released from prison and jail will be reincarcerated within the first year, which is a really significant number. And for persons with serious mental illness, I absolutely attribute a lot of that to lack of community mental health services and adequate, safe, affordable housing. We are really proud of this number. It's 8%, which is still too big, but for calendar year 2016, for our folks that we worked with who are exiting the jail, we had 8% recidivism, meaning someone who was rearrested and re-detained at the jail. So, and as Mark mentioned, we'll talk a little bit more about what our modalities are for helping to ensure that people don't go back to jail.
This is a really important slide. I hope that we just spend a couple of seconds just looking at that. Because when you see the first bullet point, those are not threshold clients, right? That's the system. And then the second bullet point is what Jill's going to talk about more today. Yeah, I mean, it's really astonishing. I had a meeting last week actually with somebody from the governor's office, a high-ranking official with oversight of justice and corrections work, and it was a really fabulous meeting and talking about what we need to do to both lower the IDOC population, prevent more people from going in. And I said, it's really not rocket science. We have the solutions. Thresholds and our partners it's housing and healthcare. And you combine that, you combine affordable supportive housing with the best healthcare and mental health care and behavioral health care and substance abuse treatment programs possible, you're not going to have this. You cannot talk about incarceration, recidivism, engagement with the justice system unless you talk about healthcare. To try to silo those as separate and distinct fields or challenges or opportunities, it's just not possible. So, sorry to interrupt.
Oh, no.
But this is
What was the response?
he agrees, so that's a good thing. So we're on the same page.
Budget?
Just clarify
Sure.
the number in your first bullet point.
Yeah.
Is that 50% of individuals with mental health issues, or is it the entire population?
It's actually the entire population, and so I would anticipate, although I don't have a specific number, that it's even higher for
But
persons
you
with
had
mental health.
another number of a percentage of those in prison with mental health issues.
Yes.
Which is high. It's a
Yeah.
right.
It's a high number, and it's kind of a little bit all over the map depending on who you ask. So, yeah.
And is this a national number or a?
This is national. Yeah, this is national, not specific to Cook County.
Yeah, I think when I don't know the exact statistics for Cook County, but when I hear Sheriff Dart and folks talk about Cook County Jail, they often say that almost 30% of the people in Cook County have a serious mental illness. And
When they enter.
Yeah, exactly.
And then when they're tested, when they're released. it goes
What
up.
percentage of those who are then released who have mental health issues do not receive the kinds of services you provide? And what is that recidivism rate?
I actually don't have those numbers, but a significant portion of persons with mental illness who are entering the jail are exiting without adequate services. Yeah,
Yeah. It's an
the capacity is not
It's an
there.
access issue and a capacity issue. We're going to come to you next, Curtis, and this gentleman has had his hand up.
He's more eager, so.
Okay, you go next, sir.
May I ask is that how worse the prison gonna be if the tax cut is signed to law by the president or any type of repeal of the Affordable Care Act? Because during this fight to save health care and mental health service, I have called Tom Dart to urge him to call Congress to oppose this Trump care bill. Because it's going to lead to cuts to all that. It's going to leave Cook County Jail already overcrowded and more overcrowded. And we know that Donald Trump and Jeff Sessions are pro law enforcement, and they are not mass incarceration. They are expanding it. And if you remember, Donald Trump told the police graduates, "Don't be nice, rough them up."
Yeah, well, and thank you, Curtis, for your advocacy and your activism. It's very inspiring, and you help all of us do what we do better, so I'm very grateful for you. Yes, this is a huge concern for us. We fought very hard to prevent the repeal of the Affordable Care Act, and as you know, in the last couple days, the tax reform bills that have sailed out of the House and the Senate and that are going to be in joint committee for reconciliation at some point really soon are really terrible for the vast majority of Americans and for many people that we serve. There's backdoor cuts to the Affordable Care Act. There's the repeal of the individual mandate, which helps pay for the Medicaid expansion that we so need and that our clients so desperately need. Affordable housing, which has been built on tax credits, could disappear or be severely curtailed by this so-called tax reform bill. So we're on it. We're doing everything that we can do with our partners locally and nationally to try to make this really bad public policy less bad. We don't know that we can stop this at this point, but we have to make it less terrible than it really is, and it is terrible. There's no mincing words. Yes, sir.
The 87 are people on your program. These are all self-selected, so to speak. They go to your program from jail, so they've got motivation. You've seen it in jail. Is this a residential program or just a visitation program?
We do not have a residential program. I think if we advance the slide, we can see a little bit more
That's really a good picture.
about what we do. Yeah. So unfortunately, we don't have access to immediate housing for a lot of the folks that we serve. Sometimes they are being discharged into shelter, placements, sometimes into housing. It really kind of depends on their financial situation, kind of what's available. But the availability for housing for someone in this situation is very limited. I think the key, most important thing, as you mentioned, that they're self-selected in the sense that they agree to work with us. The social workers at the jail will identify folks and refer them to us. And then we work to engage people in the jail to offer them the services that we can upon release. And much of what that entails is some really intense assertive outreach. So we don't have the type of business where it's a clinic-based and you give someone an appointment card and say, come see me there. Because if I'm homeless and have other things to worry about, that's probably not going to be my first step when I leave the jail. So if we're able to, we'll do a coordinated discharge with the court system, by which Thresholds will actually pick someone up and bring them to their at least temporary home. If it's temporary, if someone has a home to go back to, we can take them there. It might be a shelter placement. But then what happens from there is that we have a lot of contact with folks, and that is in the community wherever they're most comfortable. So if we have someone who chooses to live under a bridge when they leave the jail, we will visit them there. I mean, that is not a barrier to us working with them, with the goal being ideally with presenting people with options and trying to help them move forward in their recovery, access psychiatry if that's something they're willing to do, physical health care, all those things. We definitely try to work to move people forward. But unfortunately, we don't have the access to housing that I would like to see, because housing is treatment. Housing without any medication at all is treatment for someone who has serious mental health issues. And so, as I say here, these are some of the real barriers to community integration for anyone, whether they're working with Thresholds or not. The mental health treatment and community support services. And when I say community support services, I mean the ones that are really, the assertive piece is so critical. Because for folks that we see, typically we work with people who've had a lot of time in multiple institutions, whether it be nursing homes, as Mark mentioned earlier, hospitals, the streets, prisons and jails. And if people don't have access to community support services that work for them, which may involve the assertive outreach as opposed to someone going to clinic appointments, then it's not going to work. It's not going to stick. Again, a barrier, limited supply of safe and affordable housing. It's something we're always working on, trying to get relationships with landlords. I mean, we have someone who has a criminal background and it's going to show up on their background check. Is someone going to house that person? Oftentimes, if the individual is willing and to let us disclose that they're working with Thresholds without giving more significant information, we might have some landlords that we work with closely who understand that we'll be helping that person in their housing placement and ideally staying there, or helping mitigate any issues that might come up. Barriers to accessing Social Security and Medicaid benefits. Medicaid's a little easier now, but if you don't have an address and you didn't have anyone to help you with it before, you might not have Medicaid. Depending on how long someone stays incarcerated, if they had Social Security benefits, they may get cut off, in which case they actually require you to reapply from scratch, which is a very long process, with lots of denials even for the most severely ill individuals we serve. And then, of course, lack of employment opportunities. One of the first things that many of the folks we serve say when you ask them what they want is they want a job, which I think some people might not think that would be the first thing people would say, but it absolutely is. I mean, I think people want to be able to stand on their own 2 feet, take care of themselves, be a part of society. And so we work really hard to help people get there.
I'm going to pass her a cup of water because she is gone.
Okay, thanks.
30 minutes.
Did I talk for 30 minutes?
No, you've been amazing. I want to add one thing. So the slide with the 87 and 8%, it's very impressive. That's a very small program that Jill is describing, relatively small to the 15 to 17,000 people we serve in a year. Last year, and the number of people at Thresholds, correct me if I'm wrong here, with a history of justice involvement is much higher than that 87 that you mentioned.
Oh,
But
sure. Yes, and we have those were our new people that came out of jail. That doesn't include the existing members.
That's right. So that was one particular new program.
Yeah.
So hundreds and hundreds, as Jill stated at the very beginning, of people with serious mental illness and homelessness have had interaction with the justice system, have been arrested or booked in Cook County Jail. And so that means that we serve hundreds and hundreds and hundreds of people with a history of justice involvement. But last year, when you look at all of our members across the board, of which we have over 10,000, the arrest and booking rate in Cook County Jail was 3%. So as good as 8% is in this program, our overall rate of arrest and booking in Cook County Jail was 3%. I mean, if you think about that in the context of how many people in jail have a serious mental illness, and then you think what tiny percentage of thresholds clients are involved in the justice system today, I mean, it speaks volumes. There's a causal relationship. This is not a correlation. There is a causal relationship between having a serious mental illness and going to jail. There's a causal relationship of having serious mental illness, having thresholds and or our partner services, and not going to jail. This is not correlative. Yes, ma'am.
I wanted to learn a little bit more about the time of diagnosis. Is there some system in place here in Chicago or County when you enter into prison, either as a young person, just to screen for depression or serious mental illnesses? Or when does the diagnosis actually get?
You know, it really depends. As a young person, I'm not as familiar with the juvenile justice system, but I do know that they do assess for that there. The jail at the intake, they're doing a really brief screening to determine placement in the jail. So someone who screens and self-identifies, it's usually more of self-identification oftentimes as opposed to kind of a new diagnosis.
Or through medication.
Or through medications. If someone gives a medication history, a hospitalization history, then they might get placed in CIRMAC Health Services. And someone's behavior in GP, general population, might be such that they get moved or are given the opportunity to move. But there's, as far as I know, there's not a real scientific kind of capturing of that information.
Does Thresholds have any programs having to do with diversion strategies for people who are arrested and convicted? You're talking about treating people in the jail and as they leave, but this question of how we divert people from incarceration upon conviction, is that part of your program?
Yeah, so Jill can talk about that, and I'll talk briefly. I'm one of the governor's commissions called Adult Redeploy Illinois. This is a very exciting, though small program where we're working with counties throughout the state of Illinois to divert people, mostly working through problem-solving courts, mental health and substance use courts, and now a veterans court, I believe, as a way to divert people who have committed nonviolence related to that. So that's one example of how Thresholds is involved at a policy level in diversion, but Jill can talk more practically from a service perspective, how we work with courts and with bond court, et cetera.
Yeah, we unfortunately there's not a lot of front door diversion. Usually someone has to kind of go through the door to get access.
Right.
One of the things that we do in addition to participating in some of the problem-solving courts is that we do a lot of court advocacy. So we've been able to do things such as present our information to the judge, and many of the judges and public defenders and other state's attorneys have come to know Thresholds. And if someone is going to be working with Thresholds, they might be more likely to, say, put them on probation. Or we might be able to get them to not have them be on electronic monitoring, because oftentimes if someone's on EM or electronic monitoring, they're not able to get movement to go to psychiatrists and to get things done that need done. So we do a lot of work there. I'd like to say there was more work done at the front door. I mean, one of the latest changes, which maybe Mark can speak a little bit more to, is that there's been a reduction in bonds for folks. So there's been Judge Evans put out a mandate regarding looking at someone's ability to pay in relation to what their bond is. So there are more people getting out the front door perhaps before they go behind the walls of the jail, but there's not necessarily something capturing those folks at the door. That's the piece that's missing.
Yeah, I don't have enough information. I know that there's been a lot of success in the last year, including the last couple of months, in reducing bail bonds. So this is going to be a huge step forward for us, I think. I think another type of diversion, again, which I'm going to ask Jill to describe, is our work with the police department, for example, because CIT, which we rely on, right, crisis intervention team, training and implementation, I think is really critical to our working with the police and with clients to not necessarily result in either arrest or incarceration.
Right, yeah, so there are a number of officers throughout the city who are trained in crisis intervention, which is a 40-hour training. Thresholds participates in doing some of the training for officers who have an interest and are vested in working to de-escalate situations in which someone has a serious mental illness and there's an issue going on. And historically, perhaps during that situation, someone might have gone to jail. However, the goal for CIT is if someone is very erratic and their illness is such that they need to be in the hospital, is to divert them to the hospital. And Threshold's been able to work with CIT officers to help with some of our members who we were concerned about and who we want to make sure don't get arrested, but we know that they need to be in the hospital. And it's done in a much more caring and gentle, kind way than maybe historically would have happened. So kind of that's kind of a front door diversion piece that is really important.
Yeah. Yes, ma'am.
I realize every case is totally individual, but is it possible to describe maybe a typical case, one of your success stories you referenced in the 8%, 87, and just take us through what happens from the day that individual leaves the prison, who meets them, what they do, what physically the Threshold's able to engage them with to make their life successful?
Sure.
Great question.
That's a really great question. I'll try to do an abbreviated version, but in an ideal world, let's say that the person we have been able to do a coordinated discharge with the courts. So what that would mean is we'd be talking with the individual before they leave. We'd have a plan of where they're going to go, and we would actually meet them at the door when they're getting discharged from the jail.
So
we're physically there.
And this is someone who doesn't have a family that would be there for them.
Typically, that's the population we serve, correct. So another piece, which is a really important one, is that they will give folks a 2-week prescription of medication upon discharge from the jail. However, they no longer dispense that at discharge from the jail. You actually have to go to Stroger or Cook County Hospital to pick up the prescription, which is another kind of gauntlet to get through.
And if you're diabetic.
Exactly. Well, you don't need Medicaid there, so you can get it for free.
But if you're diabetic, you have no way to store your insulin or any of that.
No, exactly. So those kinds are really critical too. So we help people through that, and sometimes we get there and we find out that the scripts weren't called in. So we call our good friends at CIRMAC and they call it in and we get it and we do all that good stuff. And then we're bringing the person to whatever we had decided upon would be their housing. For some people, it could be a family member, it could be a friend, it could be an SRO placement, single room occupancy hotel, or sometimes it's a shelter.
But that's been predetermined before they leave jail.
Correct. We're not just trying to figure it out on the fly when they get out. So at least we have a plan, and they know what it is, and they've agreed upon it. And so once someone's there, ideally they have all their meds, all those good things that they need. We do have a small client assistance fund that helps us with getting basic needs for folks, because oftentimes people come out needing clothing, needing hygiene supplies, all of those basic needs. And then we will make sure that they have access to psychiatry and physical health care, which isn't always easy. Even with Threshold, we have our own psychiatrists, but they're often booked. So we're searching far and wide, depending on what area of the city the person's in, to get access to that, but it's really critical, and we make sure we're on top of that as well. And then we're working with folks on really everything that most of us want, right? To have a safe, affordable place to live, to have some positive relations in their life, to get a job if that's something they're interested in, to manage their physical and mental health symptoms. So it really depends on the individual, because everybody has different needs. So we don't have a prescriptive, this is exactly what we do for each person, but it's really based on what that person is asking for and what they're feeling like they're ready for in terms of services we provide.
Because we have levels of services without going into the details of them, right? Like the most intensive would be called assertive community treatment, an evidence-based practice with a total team approach that includes a psychiatrist, a nurse, an employment specialist, a case manager, a person with lived experience on these teams. And then we have sort of less intense called community support teams. These are just Illinois designations for the kind of service. It's ACT, but lighter touch, and clients with still pretty heavy needs, but not the intense assertive community treatment needs that they have. And then even at a lower level of community support individual, which is sort of a intensive case management in sort of lay terms. So we have a variety of levels of intensity of service based on demonstrated client need, and it can fluctuate, right? People can be at one level and another level. It's about there not being one size to fit all, and there not being, one size doesn't fit all. Yes, sir, and then Curtis.
Yes, I don't know how many more slides we have, but my mother used to say that anybody who's not a psychiatrist, by the way, anybody who infringed society's laws must have had a mental illness. Now, that of course is a powerful incentive to obey stop signs and things like that when I was growing up. Nobody thought it was a whack job. But I'm wondering whether the burgeoning demand for threshold services could be attributed to three factors which occurred, coalesced in the 1970s. The first was the deinstitutionalization of people who were previously housed in mental health facilities because they were no longer dangerous to themselves or others. Secondly, the widening pharmacological scope of recreational drugs, be they cocaine, crystal meth, and other substances. And third was the increasing public acceptance of the notion that substance abuse was a medical problem and not a moral problem. So my question is whether you have, given that this is a religious community work involved, a faith-based approach to the problem of mental illness within the criminal justice system. Chaplaincies, some sort of group faith where we all come together and recognize that we are all part of community of sinners who are in need of God's grace.
Yeah, wonderful. And I think you summarized sort of the last 40 years of all the causes and correlates of the expansion of the need for our services. But you want to talk about how we support individual members in their faith journey, because it's a really critical part of what we do. While we're not a faith-based agency and we don't have chaplaincy, almost every member I have met through the years, not every, that's an exaggeration, but so many are involved in faith communities. And I know that we're incredibly supportive of that as being part of their recovery. So,
yes, absolutely. I think, one of the key pieces to community reintegration is integrating in the communities, being part of a group, feeling part of something. And for many of our members, that can be a faith-based community, a church group. And we are fully supportive of that. As Mark mentioned, we're not a religious organization, but at the same time, we certainly support folks in finding what works for them and in finding positive social relationships in the community. And oftentimes, a church setting is a good place for that for our members.
Yeah, I mean, just earlier this week, I was with a member. We call it, just so you know, we call our clients members. Just in case you're wondering why I keep saying member, it's like, are they a member of an insurance company? Are they a member of a health club? It goes back to our founding when we were started almost as a clubhouse model, and there was an idea as institutions were closing and people with resources were able to be members of country clubs. They were able to be members of other social institutions, and the idea was that why should people with serious mental illnesses and co-occurring substance use disorders not feel that they could have a club or an association that was theirs? So for 59 years now, we've been using the term member. So I was with a member last week in one of our housing programs, and his story was so inspiring, and he talked about his early diagnosis, his living at home. He had a wonderful family and mother that supported him, but when she died, he ended up homeless. And he fortunately found thresholds, but when he was describing to me his recovery, which includes recovery from serious mental illness, his recovery journey from pretty serious drug use, he described how housing and threshold support and love was critical, And he also talked about his involvement in the Mormon Church, which for him was and is so important as sort of part of that secret sauce. And to hear him describe the community that he is building with his fellow members through that church was, it was so inspiring to me to see him so inspired and taking charge of his life. He was describing how our services allowed him to reconnect with family and friends and gave him the space to even join a church and be an active member of a church or a faith community that meant something to him. So I'm actually so glad I experienced that just this week. Yes, sir.
Yes, I'm working with a group that you may have heard of called Advanced Youth Leadership Power. It increasement of certified intervention training and the first responders bill known as Stefan's Law. As a way for first responders of paramedics, police, and paramedics to handle people's abilities, including those with mental illness. As we have seen too many times that cops have been triggered to shoot those with mental illness. And we have a one-pager, but it's not fully developed of Stefan's Law.
Okay.
One that is the alternative to hospitals, the Turning Point living room like Skokie and others, the Welcome Center Swedish, all those instead of emergency room, which is more expensive.
Exactly.
And we would like to remove police from escorting those with mental issue crisis to hospitals.
Yeah, so we're working very closely, Thresholds, the Kennedy Forum, Illinois, NAMI, many others, the Chicago Police Department, 311, the city's response team. I've been working really closely over the last year and are trying to build out increase CIT training that Jill described, improve emergency response, build capacity among community organizations to serve people and work in concert with first responders. So you're absolutely right. This is a huge critical challenge and a huge opportunity that we have to reduce unnecessary and expensive hospitalization, to reduce harm that is caused to many people with serious mental illness and their families by not having adequately trained responders. Yes,
What would you say is the gap between the services that are available and those who need them and can't access them because of their capacity? How big a problem are we looking at? If your model would solve it for scale.
It's a great question, and we should be able to quantify it for you, and I can't. All I can say is that it's this big, and it's growing.
Are there other agencies that provide the same comprehensive care that you do, or are you unique in your model?
Well, we're unique in our scope, I think, in our reach and in our history, but we have such fabulous partners in the community that are doing similar and complementary and different work. C4 is a partner agency, HHO, Heartland Health Outreach, TASK, Treatment Alternatives for Safer Communities, and then of course the county system and NAMI. So we really rely on a family of partners and colleagues to do the work. And despite all of us trying to do this, we are not stepping on each other's toes, we're not getting in each other's way. There's an absolute dearth of community mental health and affordable housing services.
Are you involved?
And it's growing.
Are you involved with All Chicago and their homelessness effort?
Yeah, we are very involved with All Chicago and all of the different housing advocacy and service coordination groups. Yeah, you can't talk about mental illness and solving the mental health and substance use crisis without talking about housing. It is, there is, Threshold's tagline is, we may have had, oh, there it is, home, health, and hope. We purposefully, when I started at Threshold 6 years ago, put them in that order. You know, it's really not order or linear like that. It probably should more be like a triangle or a circle, but it all starts with home. There is absolutely no way, well, no, Jill's serving a lot of people, in fact, that don't have a home. So I don't want to say there's no way, but it's really, really hard to be healthy And it's really, really hard to have hope unless you have a home. And living on the street under the viaduct, while it is home for many people, it is not a home. And it is not the way to health, and we know that. So until we solve the housing crisis, many things keep me up at night. The housing crisis in Chicago, the affordable housing crisis, the supportive housing crisis in Chicago and Illinois keeps me up more than anything. And I am racking my brain, which sometimes feels big and sometimes feels really small, in trying to get my head and my heart and my arms around how we solve this. I think it's a political challenge. I am not convinced that it's a challenge of economics or a challenge of program models or a challenge of smarts. I think this is like many things, a political issue, and we have to find a political solution to the affordable housing crisis. I know you have more slides, and
It's
we're running out
okay.
of time.
We're probably about out of time. These are things we already talked about, and actually this is my last slide, so that's perfect timing. So I think with all the members at Thresholds, and this population in particular, these are the kind of things that we want to focus on with people, are what they want and feel would be useful for them in terms of their recovery. And when I look at this list, I mean, these are all things that I want for myself, and I think most folks do. And that's what's really important to remember, is people want to be a part of the community. We want to engage people around their personal goals. Stable, decent housing, of course, number one. Meaningful activities, which may involve joining a church and getting involved in that way. This one, a positive value relationship with a mental health professional. We work with a lot of folks who've been in a lot of institutions where they haven't had that. And loving relationship with a sober individual, if possible, working on that is helpful for folks too. But really engaging people around their personal goals, and ideally those include staying out of jail and living a successful, fulfilling life. And that's what we are here to try to help support people in doing.
Yeah. I know that sober here can appear to folks like judgmental, like either you're sober or you're not. And I have to say, while we want to help people get healthy and get to the recovery that they want and they need, I want to be very clear that Thresholds is a harm reduction agency. We support people on their journey, which means that people have challenges, and that some days they may be sober and other days they are not. And we don't kick people out of our services because they're not sober or they're not able to not use drugs at the moment. We do everything that we can to support them, to make the right choices, to get the right health care, to stay clean and get clean, if that's where they're headed. So
Thank you for
I just want to make sure, but
Yeah.
it's really an important point.
Yeah.
So
Thank you very much.
are we out of time? Yeah, please give it up. We could not do this work at Thresholds without Jill and her great team. I am so lucky. I'm the luckiest CEO in the world to work with people like Jill and 13 other amazing people that just give 110% every day. The love and light that is shared by my colleagues, including Jill and her team, is just, I think our success and our quality is based on these amazing people. So I bow to you, I adore you, and I'm so grateful for the work that you do. So give it up for Jill.
Thanks, everybody.
Thank you.